Okay guys, Timmy coming at you here, and today what I'm going to do is I'm going to try to explain to you neurogenic shock. Now neurogenic shock is one of the forms of distributive shock, and so you got your anaphylactic, your septic, and your neurogenic as part of what's referred to as distributive shock. So in order to understand neurogenic shock, you first have to understand a little bit of anatomy and physiology. All right, so if we look here, here's a little normal outlay of the autonomic nervous system. So the autonomic nervous system consists of the sympathetic and the parasympathetic nervous system, and they work together, like I told you before, like an old man drives a car, right? They never take their foot off the brake. They never take their foot off the accelerator. If they want to go faster, they still keep their foot on the brake. They just push down on the gas, right? So you always have some sympathetic stimulation and you always have some parasympathetic stimulation. Now, the reason it's called parasympathetic nervous system, para means around. So if we look, the sympathetic nervous system right here begins at typically T1 or T2 and goes to L2 or L3, sometimes L4 depending. Now, as you can see, the sympathetic nervous system, the nerves that come off the spinal cord of the sympathetic nervous system, right here, they then form they connect together. So what that means is that when you activate the sympathetic nervous system, you can't activate just parts of it. You have to activate all of it because it's all connected together. And again, we remember that the sympathetic nervous system is singular in purpose. Its single purpose is to prepare your body to run or fight. Now, the parasympathetic nervous system is basically going to do the opposite. It's the rest and digest. And we know that the big nerve of the parasympathetic nervous system is the vagus nerve. So let's look at this. Here's a little diagram showing the spinal cord and what it controls. Now, the sympathetic nervous system, like I said, usually comes off about T1 to about L4. So if you have a spinal cord injury, typically above T6, then the brain cannot communicate with the sympathetic nervous system. So a spinal cord injury, regardless of how it's caused, if there is damage or inflammation or compression of the spinal cord above T6, then the brain cannot communicate with the sympathetic nervous system. So in essence, with a spinal cord injury above T6, you lose the activation of the sympathetic nervous system, or in your book, it's called sympathetic tone. Now, let's look at this for a minute, right? The sympathetic nervous system, when it's activated, causes arterial vasoconstriction, right? And it causes it primarily everywhere. It also affects the heart by increasing your heart rate and the force of contraction of the heart. And it also causes bronchodilation, right? So think about it. You want your bronchioles open when you're going to run or fight for your life because you got to get more air in. You want your heart rate and blood pressure up because your heart rate and blood pressure go up when you're running or fighting. So the sympathetic nervous system is going to prepare you to run or fight. You also get arterial vasoconstriction because you don't want to be sending blood to parts of the body that are not involved in running or fighting, right? It wouldn't make sense. So with the damage to the spinal cord above T6, you lose that sympathetic tone. So what's going to happen? Let's look. Hang on. Wait, I got it. So, number one, depending on the level of spinal cord, right? If it's above C5, if the spinal cord injury is above C5, remember that the phrenic nerve comes off between cervical vertebrae number 3 and cervical vertebrae number 5, and that innervates the diaphragm. So if it's above C5, they're not breathing. So you got to support that, right? Intubate them, put them on a ventilator, at least bag them until you can get a ventilator. Now, number 2, it's going to cause massive arterial vasodilation. Where? Everywhere. So if all of your arteries were like this, then you had a spinal cord injury. All of your arteries are going to become like this. And we learned, and I'll never forget it, I think it was a Tuesday, we learned Ohm's flow law of systolic blood pressure divided by resistance, and you have to maintain blood flow. So if you have a spinal cord injury above T6 and all of your arteries dilate, then resistance to blood flow goes way, way down, and that means systolic blood pressure goes way, way down. And if you don't have a mean arterial pressure greater than or equal to 60 millimeters of mercury, then you are in shock. What caused the shock? Damage to the spinal cord, and that's referred to as neurogenic shock. Now, the other thing that can happen too, and that does, is, well, if your arteries dilate, then you would think, okay, well, gee whiz, maybe we can increase the heart rate to try to maintain blood flow. The problem with that is here. If you damage your spinal cord, then you don't have any sympathetic innervation to your heart. And as a result, you're going to get unopposed parasympathetic stimulation or vagal stimulation. So not only are your blood vessels dilated, but you have the effects of the vagus nerve stimulating the heart, and that's going to cause a drop in heart rate. So here's some of the signs and symptoms. They're going to have difficulty breathing, right? You need your brain in order to activate the intercostal muscles. So if you can't communicate with your respiratory muscles, then the only thing you can do is breathe diaphragmatically. And if it's above C5, they may not be breathing. Now, they're going to be bradycardic, and they're going to be bradycardic because they have no sympathetic stimulation, right? Remember the old man driving the car, no sympathetic stimulation, but they have activation of the parasympathetic. And we know that with the activation of the parasympathetic, the vagus nerve, that's going to decrease your heart rate. They're going to have warm, dry skin. Remember, you're going to get massive arterial vasodilation where? Everywhere, right? And we know that arterial blood is redder because it's got oxygen, and warmer than venous blood because most arteries remain closer to the core of the body. Only arteries big arteries come to the surface of the skin only in particular spots of the body. So arterial blood is red and warm, so their skin will become red and warm. They're going to be anxious too, right? If they're conscious. And then they develop hypothermia. Remember, the cardiovascular system is the radiator of the body. So the radiator of the body is all the arteries are dilating. So you're dissipating all that nice, warm arterial blood to the surface, and you're going to lose body heat as a result. And in males, they get priapism. They're going to get arterial vasodilation of the penile arteries, and that's going to cause an erection. Now, What do? Well, your first priority is to immobilize and stabilize the patient so they don't damage the spinal cord further, right? And then you want to give them an IV fluid challenge, try to raise their blood pressure, get that thing up. Now remember, a lot of that blood has pooled in the extremities. Veins have muscle, not as much as arteries, but they still have muscle. So you're going to get venodilating, right? All the veins are going to dilate. And as a result, all that blood is going to be pooled in the extremities. So you're going to decrease venous return as well. Then you want to give them some vasopressors. So you want to give them norepinephrine or epinephrine. So what have they lost? They've lost the effects of the sympathetic nervous system. The neurotransmitter for the sympathetic nervous system is norepinephrine, and the hormone of the sympathetic nervous system is epinephrine. So you want to replace that. Dopamine's also given. Dopamine can prevent rapid increases in your heart rate, and it also increases blood flow to the kidney, because lack of blood flow, as we learned from the stages of shock, that lack of blood flow can cause hypoxia, and then it can cause the buildup of lactic acid, so they can develop a metabolic acidosis. So dopamine can increase renal perfusion, and remember, the kidneys can correct any pH imbalance if you live long enough. And then you want to give atropine to correct the heart rate. Now, depending, and it varies, this can last from anywhere from like 2 to 4 weeks. So this person is going to be in the ICU. They're going to be on these vasopressors, right? They're going to be intubated, and you're going to try and stabilize them until you can get past this point of the neurogenic shock. Now, let me just make this statement real quick, all right? Now look, there's a difference between spinal shock and neurogenic shock, right? Neurogenic shock is what I just talked to you about. Spinal shock is what occurs as a result immediately after the spinal cord injury. So spinal shock, this is what we're talking about here, spinal shock. They're going to have total lack of function below the injury. They will have decreased or absent reflexes and flaccid paralysis. That's why if you ever watch football games and a guy takes a pretty good hit, like a helmet-to-helmet hit, and he's laying on the ground, the announcers will say, "Oh, I saw him move his foot." Well, they may or may not know why that's a good thing, but I'm telling you why that's a good thing. Because spinal shock, if a person's in spinal shock, they have damage to their spinal cord and there's some type of inflammation going on. And if they don't treat that, they can lose function below the site of the injury. And again, this can last for weeks or several months. And then at the end of the spinal shock, they're going to start getting some of that muscular reflexes returning. So they're going to be hyper-reflexive after the spinal shock is resolved. And their muscles will be spastic. That's why in treating long-term spinal cord injury, right, paraplegic, quadriplegic, you got to do range of motion really well. Now, the other thing too is remember that when a person has a spinal cord injury and they go into spinal shock and or neurogenic shock, that they're going to get that venodilation. All right, so all the veins of the body, and remember, the veins store extra blood. So all of that venous blood is going to be pooling in their legs. So, and remember, blood that doesn't move clots. So one of the other managements for people with spinal cord injury initially and long term is anti-thrombolytics. Right? You got to give them some heparin or Coumadin to prevent that venous blood. You also want to give those compression stockings, those anti-embolytic stockings. Sometimes they'll put those sequential decompression devices while they're in the ICU to keep the venous blood moving back to the heart. So that's a little explanation on neurogenic shock. Remember, it's basically a distributive shock, and it's going to cause arterial vasodilation, loss of sympathetic tone, and as a result, the treatment is to give medication that mimics the sympathetic nervous system, and that's exactly what they do. All right, so I hope that helped.